All right. Hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the Bioskills of the Northeast studio in Fall River, Massachusetts. Today we'll be discussing primary care partnership with Doctors Jessica Manyan and Michelle McKenney. So before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. In Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centreville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. And also, please remember to leave a review. It's greatly appreciated. So first of all, let's start. If you could maybe tell us a little bit about yourselves, and I'm not sure who to start with, but we'll start over here.
So I am, I've been in family practice medicine for over 20 years. So I started out in Rhode Island, and I started in private practice. So I was trained in New Jersey, basically.
Okay.
I started in private practice in Rhode Island.
Mm-hmm.
And then I've always been involved with education. After a few years, there was a group that got together and started a residency program at Kent Hospital in Warwick, Rhode Island.
Mm-hmm.
And so I eventually became the program director there. So I spent about 12 to 15 years doing that.
That's great.
Yeah, it was amazing and fun and a lot of work. And as it got bigger and bigger, I had less and less time with my patients, which was the balance became to a place where I decided I wanted to go back and do more direct patient care, because it was one thing when it's less administrative work but more teaching, but it just became less of all the fun stuff. So
yeah, that's a hard balance to strike, to do both. You had a full practice at the time, and
when I started, I did, but then it had to get smaller and smaller.
Right.
So in any event, so I came to Primacare. And it had, we'll talk about that more later. But I came to Primacare, met Dr. Hood and Dr. Ottenstein.
Right.
And it was a really good fit because they have a practice that's a little unique that we'll talk about later.
Sure.
And it has been a really great place to be. I've always enjoyed teaching, and that's one of the things that we get to do, and learning. Mm-hmm. And also doing sort of movement. And I've been involved in martial arts for, like 15 years. And so more so Tai Chi and Qigong and things like that now. So that has been a kind of part of what I do. And at the practice, it had been more integrated in the practice. So it worked out really well. So
that's interesting. So you can do some different things that you can't do in a typical primary care practice. Yeah, great.
Jessica, before we move over to Dr. Michelle McKenney, I just want you to know that I am also a black belt, but in Six Sigma.
Yeah, I know. When Nancy first told me that, I'm a black belt, I was like, wow, really? But it's Six Sigma is.
I don't.
It's process improvement.
Yeah.
I get it. I know what it is now.
So she's a black belt.
Yeah,
in that, so.
and all that.
Harder,
yeah.
I think.
I don't know.
You have black belts and nothing.
Well, tell us about yourself, though, Dr. McKenney.
So I'm also family medicine trained. I graduated from the University of New England College of Osteopathic Medicine, and actually went through Dr. Manyan's residency program in Rhode Island. I did a small stint in OBGYN before switching over. And then landed in her program, where it was definitely a wonderful experience, but it was interesting because we were kind of growing the program at the same time, trying to learn. So, and it was at the same time as patient-centered medical home was coming into fruition, and we still had paper charts, and we transitioned everything to electronic health records. So it was very interesting transition. But I did go through that program, and then I worked in the area doing outpatient primary care for about 13 years. But just really became really burned out from the traditional model. I am certified in obesity medicine. I did that in 2019, and I did strictly obesity medicine or medical weight loss for about a year and a half. for a number of different reasons. I love helping patients just get healthier,
Right.
identifying obesity as a chronic disease and the root of many other chronic diseases. I really felt passionate and still do about that. But then I also missed primary care and doing all the things, right? So Dr. Manyan and I have kept in touch, and we kind of were talking, and it just so happened there was an opening at Primary Care Partnership. So it was just kind of really serendipitous. And so I started there June of 2025.
Okay, great. That's excellent.
Yes.
So probably a lot of our listeners out there don't really know how your practice differs from a conventional primary care practice. Maybe you could talk a little bit about what exactly it is, and what direct primary care is versus regular primary care or concierge medicine. They're all
all of the things, because there's a few out there now, and probably will be more. I think so concierge medicine is probably the most familiar as an alternative, and it's been around for a long time now. And it was more of a marketing kind of, initially the big difference between direct patient care and concierge care, which the similarity is that they both require some sort of fee to be paid on top of regular insurance, or in some models, not around here as much as in the South, instead of. Some people use DPC instead of and have other systems set up. But for us here, the big difference is concierge medicine was marketed as a more of exclusive, you're going to pay a much higher fee. And it was really about access, a little bit about sort of extra testing and extra sort of care planning, but really about access, about being able to get in touch with your doctor sort of whenever, and having a cell phone number to call or an email or whatever it is. And they tend to be, most of the fees are a little bit higher in general than a DPC model. So in the DPC model and the concierge model, usually those doctors are still taking insurance. So they're still charging copays for visits and all of that, and participating with insurance. And they may even have a practice, those are all different too. They may have a practice where there's a small percentage that are concierge and the rest are not concierge. So with DPC, there is no insurance involved. So these are practices that don't participate at all with insurance. So we don't bill it. We don't provide sort of itemized bills or anything for insurance, because part of the challenge with a DPC practice is it's usually a smaller practice. So, and the whole idea is that we're spending that time helping the patient with direct medical issues or direct coordination issues. And we would rather not spend it, making the billing very simple, having a flat fee every month, and not having extra fees for visits or extra fees for a procedure that we're going to do. That's our particular model. But DPCs come in all shapes and sizes. It's a response. The model is a response to frustrations from both, I think, physicians and sometimes patients about time spent in the visit and access.
Yes.
So the practices all have a much smaller patient load. So, you don't have as many patients in the practice, so that you can spend more time with each person when they come in, and also find a little bit better balance.
Right.
So usually for the physicians, they are not spending as much time at home charting, and spending that time, like I said, more in the visit. So DPC practices have been around not that long. They started sort of in the early 2000s, primarily as a response. And I would say many of them started because of the same reason that ours started. When Dr. Hood and Dr. Ottenstein got to a certain point about 10 years ago where they were considering retiring, and as an alternative to that, Rich Matus suggested, as he wisely suggests so many things, looking at this model that would kind of provide a little bit of a better balance and keep them in practice and in the community practicing for longer, which was, I mean, I'm incredibly grateful for, and I know. So that's in a nutshell. They're smaller practices. They have a monthly fee. Some of them do annual fees, and the fees can vary from anywhere. Typically now, depending too. So if some practices, like I said, if they have a bigger sort of population of children, if they're in an area with a lot of children, so they may have a smaller monthly fee. I've seen anything from $60 a month to $400. So you get it. It varies based on what's happening in the practice.
Sure.
So that's kind of the.
So it's not insurance based. It's out of pocket.
It's all out of. So and it's this is why it's you see it mostly in primary care settings. So to go back to the whole idea of how we got here, it kind of started with the patient-centered medical home and the idea, which was a well-hearted idea, that if we use these new computer thingies, we'll be able to track patient health, which was a great idea. We were all excited about the idea of, you mean I can just pull up the number of my patients that haven't had a mammogram? That's groundbreaking, and it was, but it sort of morphed into a lot of administrative work being pushed back onto the primary care physician or the point of care person. And so that, we've worked for a long time with efficiencies and getting things like scribes and dictation and to try and make it easier for PCPs. And for some people, it really works. And for other PCPs, it doesn't. And, I'm one of those people that it didn't really work for, that I would, especially I think if you would, and I would end up just for hours at night. And this is just a better way for me personally. It's not it's a response model.
Yeah.
Yeah. So
go ahead.
The patients can still use an HSA card, right?
Yeah.
Do you want to talk about that?
They can. I don't know all the details of it, and I think that's fairly new. But they can use FSA or HSA funds to pay for
That's good.
any fees associated.
Thanks.
There was some legislation that was passed last year.
That's huge.
It was, but it really is dependent. That's dependent on their employer too, because the employer sets the requirements for the FSA and the HSA. So if they say that you can, and most I think are, but it just depends.
So when you say that there's, let's say, better access per se, because you have a smaller panel, someone is ill and they need to come in, they can get in to see you. Do you give out your cell phone and that type of contact information to all your patients? Because I think that could be a challenge for your personal life too.
Is that the concierge though?
Well, I don't know. Tell us.
I can't speak for all practices, and that was certainly something when I was first starting. When I was talking to Jess, I'm like, oh gosh, my patients are going to have 24-hour access to me. I kind of had like PTSD, right?
Right. Yeah. Anxiety.
Trying to reclaim my time, not give more of it away. But she and Kathy had reassured me that it would be okay. And it really is. So we use an encrypted messaging app because, your messaging phone is not secure. And most patients, I think, use it. For others who are not super, comfortable or familiar with their smartphone, they just call and they can get the answering service. And then the answering service can get us directly. But we pretty much, we are accessible to them 24 hours a day, 7 days a week. But I find that because we can often spend time during the day, if they call the office, they're going to get a person. They're not going to get a call center.
Right.
They're actually going to get a person who knows them, which is really nice too. And we will either do a telemedicine visit, or we can often see them same day or next day. So most times we can really take care of whatever we need to take care of in the office real time.
Right.
And so I would say because of that, a lot of after-hours calls or weekend calls don't really happen. But they do occasionally, and then we just work together as a team, covering covering our messaging app.
Right.
but we work well together. So like last night I was at level 99 with my kids in a noisy atmosphere, and a page came through, and I texted Jess. I was like, can you grab that for me, please?
Yeah.
So we try to work together as a group. So we have our own patients, but we take care of them as a team.
Yeah, that's good.
So it's really nice. So it works out beautifully.
Good.
What does your typical day look like compared to what your day, like last year, looked like?
Yeah, right.
You know, just because I know you've been creating a better balance too, but
sure.
you were crazy. You have, like you were saying, how many patients?
Well, it's like most primary care practices. It's like a patient every 15 minutes, but I don't do that anymore.
Right.
And you guys?
Right. So no.
It's not like that. That's why we do what we do.
I don't do that anymore. But.
So it's and that's the challenge. It's like and one of the things that has been so interesting, because we came sort of, I joined the practice in 23, so I'm not that much older in the practice than Dr. McKenney, and I had the same reservations. I was thinking, oh no, and we've been taught all our lives, don't ever let anybody contact you outside of the answering service or this or that, because there will be no end to it. And one of the things that we saw was that when you decompress the amount of anxiety people have getting to you,
Right.
They don't need to call and it's a smaller practice. So
Yes,
it's just a
that's
smaller
a big
practice to
difference.
begin with. But so that fear was definitely there at the beginning. And our typical day now is, we might, a really busy day I had a couple weeks ago, 13 people.
Okay.
And that's a lot. And, I know them and
what your models.
it's urgent, but then it might be, I might have 3 people in a morning because we have a new patient. So a new patient is usually an hour and a half because we go through everything. I want to know. And when you have, that's the other piece that we find, when you have time to look at everything, you find things places where you can help that nobody had really thought about.
When I was researching you guys, I'm so glad you said that, because in one of your reviews, that was stated very boldly, like you found things that they didn't think any other physician would have found because of that relationship, and that's so important. I've been sitting here listening to you, and I've been wondering, okay, why am I paying out of pocket? Like, what's the difference? But it's so invaluable. Like when you're heard and when you have that relationship with your physician, it's like there's no price on that.
And that's the thing there's a big downside to this, obviously, which is that, it's kind of like you want it should be normal. That should be what we do. But it's just the system, as we all know, our system has been struggling to make everything work.
Right.
And so, there's...
Well, it's hard because, like, I go into my primary care physician knowing that I have, like, 15 minutes. And I'm like, okay, I'm just going to go over, like, the top 3 things. But, like, that 5th or 6th thing might be the thing that turns out to be important because I don't have the knowledge that he does.
And
right?
You're relying on yourself.
Right.
You're not clinical to decide what's important and what's not important, and what you're going to talk about now and what you're going to wait to talk about 6 months from now.
And then in the back of my head, I have, oh, the poor thing, he looks like he's busy. I don't want to make his day like, you know what I mean?
So that when I had to get past the fear of, so we don't give out our cell phone, but we have the app and we have email and we have our answering service. But again, when you call, there is a huge difference that when you call an office and you get a person that you know and that knows you, than when you know that you're going to call and be on the phone for 15 minutes just trying to make yourself heard. But yeah, so then when you get past that and new patients come in for the first time and there is that pressure, and there's a big list and, I don't know if we're going to be able to get through all of this. And you remind them, no, we will.
It's okay. It's okay. We've got the time.
Yeah.
Yeah.
So
I feel like when I was in kind of regular primary care, there became a point in time where it was like me versus the patients. Like we weren't on the same team.
Right.
Right. Like
your agenda.
Yeah. Right. It was a kind of a list I had to get through. They were in the way of me getting home to my kids or, getting to my weekend. And so whenever someone might call after hours, and this might be kind of you know, maybe I shouldn't say this out loud, but it was like when they would page, when they page it, you'd be aggravated or annoyed. Oh gosh, like what does someone want now? But now our patients they're people, right? Like we know them well, we know their histories well, we know their family members. So when they call, it's not like, it's like, gosh, like what does Cindy want? What does Cindy need? Is she okay? And so the approach, it just changes the dynamic entirely.
I'd love to do research on this to figure out what burnout rates are. They have to be drastically lower with this type of structure and this type of model.
So that's the other interesting thing about it to me, from academics, is there's not a lot of research on it, because there are some places that are doing it, but it's not a model that is easily replicated because it relies on the patients to pay. And, not that they're not already paying for a ton, but it's an added fee now. And the whole thing, I mean, our time went down to 15 minutes because of our payers.
Right.
And then there's loss in our system and all of that stuff. But there are some places have done research on it. And generally speaking, there's a lower hospitalization rate and there's a lower for the patients, generally speaking, or satisfaction with the visit.
It is a certain segment of the population that can pay for that. So,
a lot of
It's not going to be all comers are going to be able to afford that.
It's certainly like I worked at Thunder Mist for like 10 years, and I love working at Thunder Mist for a few reasons, because it's sort of like,
and that's like a community health center.
It's a community health center, and has a mission to reach patients who otherwise would not be able to get in, and because of that, they have like lots of services and lots of support. So it's sort of that middle ground. So there's these ends of the system where there's services and support and focus and attention, and then kind of everybody in the middle has to struggle with all of the frustrations that we've been finding in the system.
Right.
But there are some interesting things. Again, like we're here in New England. It's a sort of doctor-rich, healthcare-rich area, meaning we have lots of resources and we have lots of people. But in other parts of the country, like the South, where there's actually a lot of DPC practices, there are lower, so it's not going to be exactly the same. You might have more of a traditional practice where maybe you get 20 minutes with your doctor. Maybe you get a little bit longer and you have a little bit better access because they're a little bit smaller, but the monthly fee might be a lot lower. So there's different ways to do this. And it's just dependent sort of on what you're doing and where you're doing it.
Do we have enough doctors in the country, though, to do, we can't convert over to this because we have enough right now just for traditional primary care. That's right. That's a problem.
And does it affect your person? This is a very personal question, but I'm going to ask it anyways. Does it affect like your personal paycheck, like because the productivity is lower, or does that?
Usually it's a little lower, but
balance it out.
Yeah, it really depends on how you do it.
But then it's just what you're prioritizing, right? Balance of life and
right, and yeah. So you can. Generally, it has some effect. It just depends on how you design it. Is it a micro practice? Like I was looking through and I saw that one of our old medical students has just started up a DPC practice. And I believe she's with one of the, I'm not going to say who it is because I don't know exactly, but I think she's with one of the companies now that is sort of franchising this. Because so then you get into that where, there are some companies that will find individual, they'll recruit people to do a DPC practice and they will give you some support and some marketing and some extra thing, which allows you to really do it with almost no staff. So then, it's a micro DPC practice. Okay. So micro practices were another thing that we're starting. And
how many patients would a micro practice have?
Give me vibes. I shouldn't think negative,
but it really is just what it means is you don't have staff.
Well, another meaning is your overhead expenses.
Their overhead.
So it's just kind of
you use an electronic health record that's web based, and you have a scheduling, and patients put themselves in. So it's all sort of web based, which is going to work for some people. And
Right.
Well, it just almost gives you vibes of like a HOA, like everything's good at the beginning, but then like something out, there's like more demands put on you down the road. I don't know.
But then,
You mean the micro practice or
The micro practice. Like, I don't know, like if it's franchised, it almost,
I don't know. I
don't know.
Yeah.
Maybe it's wonderful, but
And it might be just a way for people to get started.
into
There might be, I don't know anything about it. So they may have sort of like a 3
like
or
you
5 year
control your
washout.
own structure
I
now.
looked into something like that similar before I joined Primary Care Partnership, and it's like they kind of, front money to get you started. They help with marketing. They help, help with all of that.
Zap your website.
Right.
They take your first
Physicians aren't free, right? And
You
then
get something out
once
of
you get started, you will give them a percentage back of what your surplus is and kind of pay back what
What the startup
costs were. So
what does a DPC practice, a typical one, have as far as a patient panel?
You mean the numbers?
Yeah.
So anywhere, usually it's smaller. So anywhere from sort of 300, 200 to
500 or 600.
800 I've seen.
So it's pretty small.
Depends on how it's run.
Yeah.
What the
Much
Again,
smaller than a typical. I'm not sure exactly, but I mean, most primary care docs are in the thousands.
1,000,
Right.
1,800 to
I
say
think that-
2,500 patients for a full-time primary care doc is pretty typical.
Although there are some real sizing measures going on, I think that these days. With the new commitment that I think Lifespan is making to primary care in Rhode Island, they made a commitment to recruit something like 20 primary care doctors who would all have panels of no more than 1,200, I think,
Wow.
which was ambitious.
Yeah, that's
We'll see if
Yeah,
it
that was
works.
a lower number for
Right.
from time. But I do want to add something because you had commented about how this really doesn't solve the primary care
right.
problem, which is vast. But I can say that it's certainly keeping me practicing medicine longer,
Yeah.
and I think with Dr. Hood and Dr. Onstein, they're not here, but I think the same thing. It allowed them to kind of retire a little bit later and still contribute and take care of their,
Yeah, it's certainly gonna help. Certain physicians, certain patients, but I mean, I wouldn't expect any system to resolve this whole problem that we have. So
Well, and you have to be more satisfied with yourself in general and have a better feeling, because you feel like you're accomplishing things, you're getting ahead of the curve kind of. And patients, like the patient outcomes, like that's another research study, like that would, like with the education they're getting and the more time.
yeah,
And thing to think about too, though, that you appreciate, I think, as you get longer in practice and see more, is that when we focus so much on data and measurements, and we tend to spend less time talking to people. And as primary care doctors,
Right.
one of the things that we love is talking to people and getting stories and learning about what they want. Like, what are your goals? Not just what's your goal about your blood pressure.
Yeah.
Like,
right.
it's your A1C goals.
like, did you want to start learning how to paint? Do
Right.
you, so we do, this is sort of trying to live healthy and trying to
To improve quality of life.
is not just walking on a treadmill and eating less sugar. It's
Yeah, I would question whether all of this data-driven, medicine that we've been involved with for the last 2 years, I wonder if it's really actually improved, the outcomes. I don't think it has. I think it's,
unfortunately.
I think that what it's done is a lot of the data is wrong anyway.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
Well, this is the
you get a lot of data on your patients that this patient hasn't had this one hasn't had that, or and it's often
You're
wrong.
a very good doctor, though, too. Like some of those quality. No, but your quality metrics were always like fantastic, right? Little pamphlet boy.
Yeah.
But what I think a lot of the quality metrics, we're trying to answer. This is the minimum that you need to do.
I'm not always convinced that it translates into better care and certainly not better interactions with patients.
Yeah. So before we came, I looked up because I never want to say things that I haven't looked up recently, because we've all seen the graphs where our longevity in the United States and we're at the bottom of all of our 81. And I did, and we're still down there, except for one that we were at the top of was care processed.
Yeah.
And what is that? And it basically said something along the lines of, which I forgot to take the printout, that we printed out all our notes and we forgot, along the lines of provides processes that everybody agrees high functioning systems need to, provides these things like preventative care, counseling, and provides them all, which to me says that we can prove that we do because we've measured it. But prove it, like, are we, it's kind of like teaching to the test. Are you teaching somebody how to spell the word without teaching them what it means? Yeah. Because I think that's what...
It's not translating to...
Yeah, it's not translating to better health, because we're sacrificing all of that other stuff that doctors do, like knowing your patient and knowing, well, if I send you to this specialist, are you going to come back and yell at me because you didn't get along with them? What's the good match for you? How do I approach you when I'm talking to you about starting on a blood pressure medication in a way that's going to make you not leave my practice? Because I know you don't want to be on it. So those are all things
that's the whole art of medicine.
Right. Yeah. That you need time to do. You can't. Yeah. Doesn't have to be a vacuum.
That you have to develop that relationship to trust you ultimately, and that takes time. It doesn't happen.
It does.
15 minutes.
You can't do it in 15 minutes. I do think that all of these processes we put in place over the last couple of years has helped. Probably as you get that data. Mary Smith hasn't had her mammogram, or Joe Brown hasn't had his colonoscopy, but it has really done nothing to help with relationships or anything like that. And part of getting people to understand the importance of those tests is to have some time with them too. It's not just having a clerk call them up and say, hey, I want to schedule it for this. That'll work with some patients, but others, you really have to sit down and talk about, why is this important, right?
Right. Or why don't you want to do it?
Why don't you want to do it if they don't?
Tell me why.
Right.
Let's talk about that, because, and that's sometimes it's a really long conversation.
It is. It can be.
If you've already done all your checklists, you might not. But yeah.
So, what? How do the DPCs answer to quality metrics? And I guess you're not answering to insurance quality metrics.
I don't.
But like, how do you then make sure you're maintaining your practice where it needs to be?
So we can still access data on our computers. We can still, I wish I did recently because I had to re-credential. But the idea behind it is also, at least in our practice, and I'm sure they're all different, is that we call ourselves primary care partnership, because our goal is to partner with people who are already want to improve their health and want to stay healthy and do things like this. So we do a little bit of chasing, but the idea is not to say that we're going to be your paternalistic, we're not going to, but we are going to be there to say, here's the recommendation. I think you should get it done, but if you don't want to get it done, I'm not going to harangue you, or call you again, or send a letter, because you're a grown up, and I appreciate it, and you have time. So that's the other thing. I can tell you why I think it's important, because we can look at the statistics together, and we can talk about your personal risk too. So those are, so I hear what you're saying is, how do you know you're doing a good job? Our goal is not to spend a ton of time doing that. So
I imagine within the structure of your electronic health record, like you're getting those flags, like boom, 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 boom,
we can do it however we would like to do it, because a lot of that comes directly from the insurance companies.
Right.
I mean, it's the Medicare measures and the HEDIS measures, and it's not the AAFP measures.
Okay. There's a disconnect there with.
Yeah. So the question again is, like, if you spend a lot of time focused on that, are you really improving their health? Or would it be better to use that time that you're looking all that up to just breathe with your patient and talk about breathing in 5 times, or a count of 5, and breathing out a count of 5. Our nurse, Cindy, and we have some amazing staff, but one of the things that she frequently does with patients who come in, and she'll read their blood pressure might be high, or she knows they have high blood pressure. Before she takes it, she say, okay, let's breathe, and and she will breathe with them and then take their blood pressure. So, I think those are the kinds of things that we focus on a little bit more.
Right. That's great. I mean,
Yeah.
it's a lot of positive aspects to this type of practice. One thing I wonder about, though, there are some challenges too, I'm sure. I mean, patients need referrals, for example, to specialists. How do you navigate that if, you don't have staff to do referrals, for example? I mean, how does that work out?
So we use the same EMR. So we just put our referral and it goes to our office manager, and then she sends it out. Doesn't matter with most insurances, but with an HMO, and this is the beauty of being in Primacare, because we can partner with providers who are participating.
That's what I'm wondering, because if you're not dealing with insurance companies, you can't really put it on insurance.
Right. No, we still deal with them on some level.
Right.
For things like referrals and prior authorizations for medications. So
do you get credentialed through them?
No, we don't need to. To send in a medication, I don't need the insurance. Yeah. So, but they can say, oh, you have to provide this documentation. We just do that. Anybody who does not take insurance, commercial insurance, or Medicare, Medicaid in the state of Massachusetts also has to register as a non-participating provider.
Okay.
And I'm with Mass Health. So we do that, and I'm not sure what the reason is for it. We do it.
Okay.
You're on somebody's list somewhere.
But if someone needs a referral to, say, a cardiologist, is your office able to do that, not being credentialed with the insurance companies? Or do you have another provider that does
if they have a PPO, or if they don't have an insurance that requires,
then they don't really, it doesn't matter.
But if they do, then we partner with a couple of different physicians within.
Okay, that's what I'm wondering, more like with the HMOs and what
we do.
You might
and then they go see that doctor once a year for the annual, and we do all of the work, and we try very hard to check all the boxes, so everything's there.
Okay,
but it's a very small percentage.
Yeah, because a lot of patients do have PPOs or insurances where they may not require that.
Yeah, our population in general too, because a lot of them are
older and are Medicare.
Yeah, Medicare does.
Are on Medicare, and they might travel too, so they don't want to keep a regional plan, because then they might not be able to use it. Right,
Dr. McKenney, what's the most important thing to you practicing in this type of structure? Like, you've been a couple places. Like, what just felt right to you?
Yeah. So for me, honestly, it was just balance. I needed to find a place where I felt like I could still be like a good mom, be a good wife, and a good doctor. And in all the other experiences I had, something was always being dropped. Right? And as a physician, and you're taking care of people, I don't want that to be patient care.
Right.
So it was very difficult decision to make, right? Because it was either getting home on time for a basketball game, or staying late, answering calls, going through
Right.
important documentation. So it was really tricky. So for me, having this, having heard about DPC, but also feeling like I was going out on a limb, right? What is this type of practice? It just sounds too good to be true. How is this sustainable? And also, having a guilt component too, understanding that, it's really patients who are in a better socioeconomic bracket. And that to me is difficult. But at the end of the day, it was, what was best for me and for my family. And I had to make that decision. And I found that it's not only patients who are wealthy, it's patients who just value their health care. And, will say, okay, well, maybe I don't go out to dinner twice a month, or, they'll find ways to cover the fee. And they just really value having, a partner, having a physician that they trust and who knows who is there.
Right.
So I've definitely found that it has brought me back to just like the roots of why, what drew me to medicine is just connect what Dr. Manyan said, that just connecting to patients, getting to know them, understanding, what are your health goals? Like what are you looking for? Because we can all check off the quality measures, right? We all know that if we're following kind of those guidelines, yes, we know that, but it allows us to take that step further.
Sure.
And kind of just really connect.
I love what you just said. I've never been asked that question. And I like my doctor. But I've never been asked, what are your health goals?
Your goals.
I love that. That makes me feel like, oh, I'm going to be part of this.
Well, you're, it's your, yeah. So, I mean, you're this, you are it.
Yeah, because that's so different than, hey, how's everything going?
Yeah, blood pressure, your A1C, your cholesterol, colonoscopy, mammogram, great, right? That's good. That's good. But there is better, and I think that
it should be a bumper sticker. There is better.
It is like we can really, because there's different ways to take care of patients, right? And I want to help patients find different ways to be healthy, to provide good quality of life. Like we're really good at helping, prolong patients' lives, but quality of life can be poor. We're just kind of prolonging chronic disease and chronic illness, right? And I just
True. Yeah, very much.
What I like about this practice too is the closeness of the providers, because if you have a patient that's struggling maybe with an expertise that you have, like nutrition or something, you're like, well, hey, come on in.
It's great.
Where you might not see that in other practices because they tend to be more siloed.
like siloed.
Yeah.
It is fun because of that aspect. We're all over here talking on the phone, and I'll say, oh, I'll just read an article about that, or we looked that up for you. I want to know that too.
Use my AI. I won't.
Open evidence. That's this. So it is fun because it's more collaborative.
Yeah.
And that's something that I felt like was missing from my
success. And you feel like someone has you back.
Yes.
So I miss from residency is one of the fun things about residency is just the collaboration with your co-residents and the departments.
And you lose that when you go into practice to some extent.
Yep.
So
yeah, feel that. So then, and this is a question for both Dr. Manyan and Dr. McKenney, is when you've seen this panel of patients for a little while now, what's the greatest challenge that you find facing the patients that you see today, and how are they overcoming some of those challenges? It's a thinker.
yeah, it is.
It's a very broad question.
That's as broad as you want to make it. You wanna jump in?
No. I'm just
So I can start. So our patient panel at this particular practice is a little bit older.
Yeah.
So we have, we inherited Dr. Hood and Dr. Ottenstein's practice.
Okay.
We're getting new patients. But I think that's part of it is so when we talk about challenges in general, for everybody,
Yeah.
they're similar in that, finding care support in the community can be a challenge. And then medications, just navigating the system.
Right.
I think those navigating the system
Aging and navigating the system. So
on a big scale, broad, big. We have not as we don't have as many housing challenges. Although I have a few patients who have housing challenges as well, and we do have a percentage of our patient population that is sort of not free, not scholarship or not paying or low paying, just because we want it to be able to continue to make it available to some of our patients who either lose their ability to pay entirely or have been with, like I had a couple that were with me when I came. And so, but for the most part, I would say it's costs related to medications not being covered or being covered incompletely, and then just not even being able to find care. So we do a lot of coordination with services, and Dr. McKenney, she's the medical director for
hospice
for community nurses,
Right.
and so that's another part of it is trying to say, all right, well, we're at this place where we need more care, but how much more, and where is it going to come from, and will I trust this person coming into my house because I don't have any family nearby?
Right.
So those are things that come up.
And the practice is still taking patients?
Mm-hmm.
Yeah.
We are. We're going to we need to keep our number,
Sure.
reasonable for all of the balance reasons, and we want to make sure people can still get in when they need. So we had at the end of last year when it's like holidays, people are out. We had a point where we were seeing that I don't know. We were scheduling new patients something like 2 weeks out. Ridiculous, right? It's not a long period of time.
Yeah.
But for us, it
It was
was
July. That's when my reschedule was when I couldn't make
a point. It was long, and we have people who come in for meet and greets. So we also we schedule meet and greets. We need to meet people and talk to them, and they need to talk to us before we can say this is going to work, because it's such a different practice model. People don't know what to expect.
Right.
So we had suspended those for a month just so that we could get, and plus Dr. McKenney had just started in August.
Yeah.
How do patients reach you if they want to potentially join the practice? Who would they call?
So we have a web page,
Okay.
but they can call the practice. They just call
either
the
one.
practice. Yeah.
So
the web page would be, how do they reach that?
That's primary care partnerships. primarycarepartnership.com. All one.
I did want to sneak something in too. So I was looking at ratings in the U.S. News, and if patients are listening out there and looking for new providers, I'm just looking at these U.S. News ratings.
Okay.
Provider follow-up, 5 out of 5. Amount of time with patient, 5 out of 5.
great.
Provider's attitude, 5 out of 5. Perceived outcomes, 5 out of 5. Patient loyalty, 5 out of 5,
Great.
meaning patients' trust in their physicians. So that's pretty good.
Thank you. Yeah. It's that's the other thing that I keep going back to this, but when people do come in for the meet and greets, what we hear is that what I was going to say is what we hear is people say, well, I had called, I had a new doctor I was supposed to see, and I waited for 4 months, and then they changed it, and I have to wait another 6 months.
Yes.
And that's heartbreaking. Or, I'm coming to you because I can't get in to see my doctor. And so that's like where, like all of those things, I feel like there's so many doctors out there that we get patients from, just not because they are not 5 out of 5 in all of those areas, but they're not allowed to be. And that's, I feel like
a really good point. Yeah. It's tough to be that in 15 minutes.
right.
Right. And then even just I feel like with these bigger healthcare groups, you're not getting to the doc, right? Because you're busy seeing your 20 or 30 patients a day. So getting, a phone call back from your doctor that day is really difficult. But even getting through to the doctor's office, because you're calling a call center and
be a
they're
challenge.
overwhelmed and short-staffed. So it's just, I feel like there's just a lot of it's difficult to even reach or access your doctor now.
Yeah, I agree.
Or to even follow up with, but my appointment, I need my appointment to be, I can't wait another 6 months. Getting that message can be really frustrating.
Yeah. So then, as we wrap this up, for both of you, another question for both of you doctors, what's the one message you'd like to leave our audience with?
I'll start.
Yes.
So, and this might be more than one message, but I would say, unfortunately, I think physicians really get the short end of the stick, right? So there's so many flaws with the system, but I feel like physicians take the brunt of the frustration, and that's not fair. And even, before coming tonight, one thing I wanted to talk to Jess about was like, how do we kind of promote this model of practice and what we do without degrading what our current physicians do? That's not the point, because I know how hard your job is. And nobody goes into medicine, well, maybe they do, but they go into medicine because they care, they want to take care of people, right?
Majority of us, absolutely.
You wouldn't go through all of the years of schooling, and you just wouldn't. And so your heart is in the right place. But I feel like because the system is so broken, the onus kind of lands on the physician. So I want the message to be your physician likely cares very much, but they're kind of trapped in this model that's really nearly impossible to fix. And what we're trying to do isn't necessarily like the answer to everything.
It can't be, right?
It can't be. But like for me personally, I'm trying to make my life, my health better, and still continue to do what I love to do.
Yes, and it'll be the answer for some patients, definitely.
Exactly.
And that's like, I would say you're your own best advocate. So there are, in the words of Dr. Hood, there are many paths to health. And this is one, but, everybody has the ability to make healthy choices and make changes and make progress without somebody sort of telling you what to do. This is the path you have to be on. You may be right. You may need some advice. So I would say just keep trying.
Right.
And if anybody's interested, give us a call.
All right. Very good. Well, thank you. It was an interesting conversation.
Yeah.
Thanks. Really interesting.
Yeah. Very interesting to hear, alternative options for primary care patients out there. It's great. Well, thank you, everyone, for listening to the show. Special thanks to Ron Gamache for our intro music, Primary Care, your trusted medical providers in Southeastern New England, and Bioskills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And Dr. Manyan and Dr. McKenney, thank you very much for being on our show. It's a really interesting conversation. I really enjoyed it. And
Thank you.
I think
Thanks for having us.
I think patients will really appreciate hearing what you had to say too.
Thank you.
Thank you.
It's great to be here.